Hi, I'm Krishna Parekh. I'm a fourth-year medical student, and today I'll be talking about uterine abnormalities and anomalies. This is going to be an overview of uterine and adnexal pathologies with imaging, and I hope this will help you study for your Step 2 exam. So this is the anatomy of a normal uterus. There are two fallopian tubes, two ovaries, a cervix, and a vagina. A normal uterus measures from 7.6 centimeters to a width of 4.5 centimeters, and the thickness is usually around 3 centimeters. And this varies depending on the menstrual cycle. So this is what a normal uterus looks like via a pelvic ultrasound. The image on the right shows a coronal plane of the uterus with the ultrasound placed transversely. The image on the left shows a pelvic ultrasound placed longitudinally. As you can see, the hypoechoic region is the bladder. Then you see the lining, which is circled, is the endometrium. And then there's the cervix, the vagina. And then the muscle around the endometrium is called the myometrium. And then you can see the rectum below. Here is an image of a uterus during the different phases of the menstrual cycle. Panel A shows clot and fluid during menses. Panel B shows early proliferative phase after menses. Panel C shows late proliferative phase, which shows a triple layer. Panel D shows secretory phase, which is thick and echogenic. So today I'll be talking about adenomyosis, endometriosis, leiomyomas, adnexal cyst, polycystic ovarian syndrome, ectopic pregnancy, teratomas, endometrial hyperplasia and cancer, ovarian cancer, hydatiform mole, and uterine anomalies. So our first case is a 45-year-old female that comes to the office with a 2-year history of heavy painful periods and pelvic pain in between periods. Her previous periods had a 25-day menstrual cycle that lasted 4 days, and currently her menses occur every 22 days and last for 1 week. She changes her pad every 2 hours for the first 3 days of her period. She's not on any medications. On physical exam, the uterus is symmetrically enlarged. The uterus is boggy, tender, globular, and freely mobile. The urine B-HCG level is negative. What is the most likely diagnosis? So our patient here has adenomyosis, which is the endometrial tissue exists within and grows into the uterine wall. This causes dysmenorrhea, pelvic pain, heavy menses, bulky, globular, and a tender uterus, and usually the onset is when you're older than 40. Definitive diagnosis is made with surgical pathology after hysterectomy, which is also the treatment. Both transvaginal ultrasound and MRI, especially T2 weighted images, are increasingly used for clinical decision making. Here is an ultrasound image of adenomyosis. As you can see the thickening between the two arrows, this is greatly enlarged from a normal uterus. These are MRIs of a pelvis without contrast. On the right is a uterus with adenomyosis, and you can see the globular, bulky structure of the uterus. And on the left is a normal uterus. So now we have a 28-year-old female that comes to the office for intermittent left pelvic pain for the past 7 months. Exercise exacerbates the discomfort. Currently, she is sexually active and no longer is on OCPs for the past 2 years because she wants to have children. Her last menstrual cycle was 2 weeks ago. Cycles are around 27 days with painful bleeding that lasts 4 days. Physical exam shows normal uterus and an enlarged left adnexal. Ultrasound reveals a homogeneous cystic appearance of the mass on the left ovary, but otherwise is normal. What is the most likely diagnosis? The fact that this patient has painful bleeding versus more bleeding indicates this patient has endometriosis. This is ectopic implantation of endometrial glands. This causes dysmenorrhea, dyspareunia, infertility, dyschezia, common cause of chronic pelvic pain in reproductive age women. And the location, timing, and quality is unique to each patient. Most commonly, patients report dysmenorrhea as well as non-cyclic pain with exercise. This causes a fixed, immobile uterus with cervical motion tenderness and rectovaginal nodularity. Definitive diagnosis is made by direct visualization with biopsy during laparoscopy. Treatment includes surgical removal but tends to reoccur. This can cause adhesions, powder burn lesions, nodules, and chocolate cysts. Conservative treatment includes OCPs, NSAIDs, and asymptomatic patients need no treatment. Chocolate cyst is a buzzword for endometriosis. So endometriosis cannot be detected on ultrasound unless it's causing cysts. MRI is helpful in determining the extent of deep infiltrating endometriosis when laparoscopic inspection is limited by adhesions. So now we have a 33-year-old African-American female that comes to the office with worsening heavy feeling in her lower abdomen this past year. Menses occur regularly in 28 days interval and last usually around 10 days with no bleeding or spotting in between periods. Her last menstrual cycle ended last week. She has had 2 first trimester miscarriages in the last year and wants to conceive. Exam shows mobile globular mass with several protuberances below the umbilicus. Her urine pregnancy test is negative. What is the most likely diagnosis? So the fact that she's had 2 first trimester miscarriages and several protuberances, this indicates that she may have leiomyomas, which are fibroids. This is the most common pelvic tumor in women, which is a benign smooth muscle tumor that arises from myometrium and are most common in women of reproductive age, especially in African Americans. The clinical presentation depends on size, location, and number of fibroids. Extremely large fibroids can cause pelvic pressure and urinary frequency and constipation. Uterus may be enlarged, globular mass, and irregularly contoured due to fibroids. There are heavy periods and dysmenorrhea, which are painful cramps, if it's located in the submucosa. As mentioned before, recurrent pregnancy loss is an indication that this patient may have fibroids. Diagnosis is done via ultrasound. Treatment is observation if the patient is asymptomatic. Symptomatic patients can receive combined hormonal contraception or undergo surgery. And surgery is usually indicated if the patient wants to conceive. And here is a sagittal sonographic view of a uterus with a submucosal leiomyoma. So now I'm going to talk about adnexal cyst. And in premenopausal women, you can see primarily ovarian cyst, ectopic pregnancy, benign or malignant tumors, endometriomas, polycystic ovaries, tubo-ovarian abscess, and most commonly follicular and corpus luteum cysts. And in postmenopausal women, you will see mainly cancer, fibroids, fibromas, and diverticular abscess. So the image on the left shows follicles in a right ovary. And normally, a woman would have 6 to 10 follicles. The image on the right shows a corpus luteum, which is a remnant of a follicle after ovulation. You can see a ring of fire, which is the peripheral vascularity surrounding the corpus luteum. So now we have a 28-year-old female that comes to the office for evaluation for infertility. The couple has not conceived despite frequent intercourse without contraception for over a year. Patient's menstrual cycles are irregular, and her last menstrual period was 8 weeks ago. Her husband has normal semen analysis. BMI is 28. Pelvic exam is unremarkable. Abdomen is soft and tender with no palpable masses. Urine pregnancy test is negative. Her serum TSH and prolactin levels are normal. Free testosterone levels are elevated. What is the most likely cause for infertility? The fact that this patient has high testosterone levels and a higher BMI indicates that this patient may have PCOS, which is failure of follicle maturation. Amounts of androgens can cause acne, hirsutism, male pattern baldness. Other signs and symptoms include obesity, anovulation or oligo-ovulation, which is a menstrual irregularity, polycystic ovaries on ultrasound. And as mentioned before, labs would include increased testosterone, estrogen, and there will be an imbalance of LH and FSH levels. Treatment is weight loss, which is first line, and then you would start with OCPs for menstrual irregulation. Clomiphene citrate is for ovulation induction for patients who want to get pregnant. As mentioned before, 6 to 10 follicles is normal in an ovary. More than 10 would indicate PCOS. A 33-year-old woman comes to the ER with abdominal pain and nausea that began 2 days ago, but has become increasingly severe over the last 3 hours. The patient has passed several blood clots vaginally. The patient has a history of irregular menstrual cycles and does not recall the date of her last period. Patient states she was diagnosed with a heart-shaped uterus 3 years ago. Her BP is 90 or 50 and pulse is 120 per minute. Abdominal exam shows guarding with decreased bowel movements. Speculum exam shows moderate vaginal bleeding with clots. A urine pregnancy test is positive. Transvaginal ultrasound shows a gestational sac at the upper left uterine cornu, which is the horn, and free fluid in the posterior cul-de-sac. What is the most likely diagnosis? What is the next step? So we have a patient who is experiencing ruptured ectopic pregnancy, which means it's a fertilized egg that implants outside of the uterus. And you know this because, first of all, you have to look at this patient. She is in hypovolemic shock from the ruptured ectopic pregnancy. She's having vaginal bleeding, amenorrhea, abdominal pain. There's cervical motion or adnexal or abdominal tenderness, palpable adnexal mass, positive B-HCG, transvaginal ultrasound reveals adnexal mass and empty uterus. Because this patient is in shock, the best step is surgical exploration. Patient has acute abdomen due to hemoperitoneum from ruptured ectopic pregnancy in the left uterine cornu. This rare type is known as interstitial ectopic pregnancy, where the gestational sac implants in the upper fundal region. Risk factors for this pregnancy includes bicornuate heart-shaped uterus and in vitro fertilization. And methotrexate is used to treat stable ectopic pregnancy. You can also do surgery during stable pregnancy, but that is up to the patient to decide. So this is what an ectopic pregnancy looks like on an ultrasound. It's called a donut sign. The image on the left shows the anatomy of where it could be, and 95% occurs in the tubes, most commonly in the ampulla, which is 70%. And then it can also occur in the ovaries, in the cesarean scar, or in the broad ligament. So this is a bicornuate uterus, which means it's a heart-shaped uterus, and you can see the heart shape in this ultrasound. So now we have a 16-year-old nulliparous female that comes to the office after a pelvic ultrasound to evaluate a right adnexal fullness. Her last period was 3 weeks ago. Menses occur every 28 days and last 5 days. She is sexually active and uses condoms for contraception. Ultrasound shows a 7 centimeter right ovarian cyst with calcifications and hyperechoic nodules. What is the most likely diagnosis? So this patient has dermoid ovarian cyst, which is a mature cystic teratoma. It's a common benign germ cell tumor. The cyst can have sebaceous fluid, hair, teeth, adipose tissue. Patient might experience adnexal fullness or can be otherwise asymptomatic. Patient may have pelvic pain or pressure, and like I mentioned before, on ultrasound, she can have hyperechoic nodules and calcifications. And the treatment is usually a surgical removal of the cyst. So, can this become malignant? Yes. The neuroendocrine part of it can become malignant. So on ultrasound, it looks like the image on the left, and visually on the right, you can see what it looks like when you cut into it. You can see teeth, hair, fat, anything that can grow out of the ectoderm, mesoderm, endoderm, and what becomes malignant? It's the ectoderm, where the neuroendocrine cells come from. So now we have a 49-year-old nulliparous woman that comes to the office due to heavy menstrual bleeding and irregular periods for the past 2 months. She states her period started 2 months ago and seems like it never stopped, bleeding heavy to light almost every day except for 2 or 3 bleeding-free days in between. Pap smears have been normal. She has a BMI of 39 and type 2 diabetes. Patient was treated for irregular periods in her 20s and 30s with OCPs. What is the next best step? What is likely her diagnosis? So this patient has endometrial hyperplasia of cancer, most commonly gynecological malignancy, and you must do an endometrial biopsy. That's very important. This patient has heavy, prolonged intermenstrual or postmenopausal bleeding, excess estrogen due to obesity, PCOS, nulliparity, early menarche, or even late menopause, or tamoxifen use can cause this. Obesity, as seen in this patient, increases circulating estrogen concentrations by converting androgens to estradiol and estrone in adipose cells. This causes endometrial to proliferate due to the unopposed estrogen exposure. Gold standard is to do the biopsy. For postmenopausal women, you can do a pelvic ultrasound. Most commonly presents in postmenopausal women, but premenopausal women who are obese are also susceptible. Treatment for hyperplasia is progestin therapy or hysterectomy. If it is cancer, treatment is hysterectomy, surgical staging, and subsequent chemo or radiation therapy. So if you're close to reaching menopause but still have an occasional vaginal bleeding, the average strip is less than 5 millimeters thick. In this patient on the right, you can see that it's 13 millimeters. The image on the left shows what it can look like. So here we have a 54-year-old woman that comes to the office due to right-sided pelvic pain that has worsened over 2 months. Her last period was 2 years ago, and she had a bilateral tubal ligation at age 35. She smokes a pack of cigarettes daily and drinks socially. She's currently sexually active and does not use contraception. Her vital signs are stable, and urine pregnancy test is negative. Pelvic ultrasound shows a 7-centimeter right ovarian mass with solid components, thick septations, and moderate amount of peritoneal fluid. What is the most likely diagnosis? So this patient has epithelial ovarian carcinoma. It's a malignancy that involves the ovary, fallopian tube, and the peritoneum. Symptoms include pelvic abdominal pain, bloating, and early satiety. Acute symptoms include shortness of breath, obstipation, constipation with vomiting, abdominal distension. So what is obstipation? So you will see when you do your surgical rotation that obstipation is the severe form of constipation where you cannot pass gas or stool. Patient may also be asymptomatic. Labs include increased CA-125 levels, which is a biomarker for ovarian cancer. Remember, there is no cancer screening for ovarian cancer. Ultrasound can show a solid mass, thick septations, and ascites. So, ultrasound is the first-line imaging modality for pelvic pain and adnexal mass, so that is what you first do. The features are concerning for malignancy than something benign or infectious, which is when you see thick septation, that is not normal. So the presence of peritoneal fluid in postmenopausal women is pathological, and it is the cause of bloating, pain, early satiety, and abdominal distension in ovarian cancer. So when you see peritoneal fluid in premenopausal women, that is common. Peritoneal fluid in postmenopausal women is not good and can indicate ovarian cancer. So treatment is surgical exploration if malignancy is suspected. You don't want to do a biopsy. You don't want to spread the cancer. So definitely do surgery to explore what it is. So the ultrasound image on the bottom of the slide shows the thick septations that you can see that can indicate carcinoma, ovarian carcinoma. So now we have a 19-year-old female with an enlarged uterus that comes to the office to establish prenatal care. Patient believes she is pregnant as she has been sexually active with her boyfriend and does not use contraception. Patient does not remember the exact date of her last menstrual period, but she believes it was 2 months ago. She has noticed vaginal bleeding in the past few weeks. She also reports severe vomiting and nausea. Patient wants to know if these symptoms are normal as this is her first pregnancy. B-HCG levels are elevated. Ultrasound shows a heterogeneous mass of anechoic cystic spaces and a snowstorm appearance. That is important. What is the most likely diagnosis? So this patient has hydatiform mole, which is a cystic swelling of the chorionic villi and proliferation of the chorionic epithelium. This usually occurs from a fertilization that goes wrong. Symptoms include abnormal vaginal bleeding or hydrophic tissue, uterine enlargement that is larger than what the predicted gestational age would be, abnormally elevated beta-HCG. Patients can also have theca, lutein, ovarian cyst, hyperemesis gravidarum, eclampsia with severe features, hyperthyroidism. Risk factors include extremes of maternal age and previous hydatiform mole. To make a diagnosis, you can check the beta-HCG levels, which will be very high. Check on ultrasound if it's a snowstorm appearance, and also do a histological evaluation. Treatment involves dilation and suction curettage, which is a DNC, serum beta-HCG levels after removing the mass, and you make sure the patient has contraception for 6 months because you want to make sure that this patient does not have choriocarcinoma, which can occur from hydatiform mole. Choriocarcinoma is a type of gestational trophoblastic neoplasia. So there are two types of mole, complete mole and a partial mole. The complete mole will show a snowstorm appearance. Partial mole will show part of the fetus and some of the snowstorm appearance. Complete mole is when you have paternal chromosome duplication. So you have a sperm that is duplicated for the genetic material, and the maternal chromosome is inactivated. In partial mole, 2 sperms that fertilize 1 egg, which causes 69 chromosomes. So you have 2 X's and 1 Y. Or it could be 3 X's. It just shows that you have maternal and paternal chromosomes, which is why you have a fetus in partial moles. So this chart explains the difference between complete and partial moles. I want you to pause the video, read the table, and understand it. Now we're going to discuss uterine anomalies. So there are 3 phases for Mullerian duct system. I'm not going to go into deep detail about it, but I'm going to explain the basics. First, there's duct formation, then there's duct fusion, and then there's septal resorption. So in duct formation, you have Mullerian ducts that form. In duct fusion, it's a fused Mullerian duct, so it comes together to help form the uterus. And in septal resorption, it fuses, so now it is a uterus. So this image shows the different types of uterus you can get when things can go wrong in formation, fusion, or resorption. Congenital uterine anomalies can occur in 1.5% of the females. For majority of the cases, the cause is actually unknown. It's usually discovered during infertility or pregnancy loss. So you're going to have a patient that continuously has miscarriages and you don't know why, you want to see what the uterus looks like. Arcuate is a uterine anomaly that is the least commonly associated with reproductive failure. So you can see arcuate is within the resorption defect, and arcuate kind of looks like a normal uterus. So this is a uterus didelphys, which is a double uterus, and the image on the right shows dicavitary twin gestation at 12 weeks within each of the uterus. I feel like this is quite an interesting scenario. So the image on the left shows what a normal uterus should look like through a uteral salpingography. On the image on the left shows a T-shaped uterus, and this occurs in women who were exposed to diethylstilbestrol in their mother's uterus. So diethylstilbestrol was a contraception that was used in the past, and after the fact they found out that females who were taking it, their female children in their uterus were affected. Thank you for watching my video. I hope you find this really useful for board studying or for your OBGYN rotation exams. Some of the ultrasound images that I presented in my slideshow may be on your exam, so it's definitely good to get familiar with seeing what anatomy looks like on ultrasound. Thank you.